Everybody can.
All right, thank you, Lindsay, for doing our presentation for the CAN meeting this month. And I'll just let you kick it off and start.
Okay, so hello everyone. Thank you, Haley, and the rest of the group for inviting me to present this afternoon. My name is Lindsay Bolio. I'm the Stroke Program Coordinator, and this is a relatively new position within the Calgary Stroke Program. So I'm really excited to be in the role and also be here today. So today I'm going to present the latest change in our stroke care, which is the transition to Tenecteplase for treatment of acute ischemic stroke. So today I was hoping to review the background of acute ischemic stroke, including some of the pharmacology and pathophysiology, and then discuss the recently published ACT trial. And then I'll describe the new practice change in Alberta for stroke care and highlight some of the nursing care that's required. And then I'll finish off with some of the key takeaways and next steps in the stroke world. So just a very brief background I wanted to provide, and I'm sure we've all heard the slogan "time is brain" many times. But it's so important because 1.9 million neurons die every minute that elapses following symptom onset, which leads to permanent damage. So fast and prompt treatment has proven to limit the infarct sizes by dissolving clots and restoring blood flow, salvaging threatened brain tissue, and promoting reperfusion, and lastly, improving functional outcomes post-stroke. So just a little bit of data on acute ischemic stroke in Alberta. Here's some percentages of patients treated with thrombolytic therapy in Alberta in 2022, and I'm just missing data from December. It was supposed to be updated a few days ago, but we're just a bit behind. So within the province, there was over 3,000 patients that presented with acute stroke. And of those, 14.1 were treated with thrombolytic therapy. And then at Foothills, just over 1,200 patients presented with acute stroke, and of those 11.7 were treated with thrombolytic therapy. So the standard treatment for acute ischemic stroke has been intravenous alteplase, a tissue plasminogen activator, administered within 4.5 hours of symptom onset. So recent studies in the last 5 to 10 years have prompted curiosities in researchers to determine the efficacy, safety, and long-term outcomes of Tenecteplase as an alternative to acute ischemic stroke. So Tenecteplase is a genetically modified variant of alteplase with increased fibrin specificity, and it's commonly used in patients with acute myocardial infarction. It has a longer plasma half-life, and it's administered as a single bolus dose. Its indications are the same, and the risk of systemic, not systematic, and intracranial hemorrhage is about the same as alteplase, so about 3 to 4%. So one of the clinical practice questions our research team here in Calgary sought to determine was the effectiveness of Tenecteplase at a dose of 0.25 milligrams per kilogram versus alteplase at 0.9 milligrams per kilogram for patients with acute ischemic stroke who are eligible for IV thrombolysis. And the key distinction here is that the Tenecteplase dose for cardiac dosing is 0.5 milligrams per kilogram, so half the dose in stroke patients. So before I review the recently published ACT trial and the new practice change in Alberta, I just wanted to provide a brief background on the pharmacology and the naming of TPA and TNK. So there are several types of TPA, tissue plasminogen activators, and most commonly recognized and used in the history of stroke care is IV alteplase, and we've commonly referred to this as TPA. So it's a protein found on the endothelial cells, and it catalyzes the conversion of plasminogen to plasmin and is the major enzyme responsible for clot breakdown. Tenecteplase is also referred to TNK, and it's a modified form of TPA, and it's actually called TNK-TPA or TNKase. So it is a recombinant fibrin-specific plasminogen activator that is derived from TPA by modifications at 3 sites of the protein structure. It binds to the fibrin components of the thrombus and then selectively converts thrombus-bound plasminogen to plasmin, which then degrades the fibrin matrix of the thrombus. So Tenecteplase has a higher fibrin specificity compared to alteplase. And just before we move on, I just wanted to touch base about the naming of Tenecteplase. So although TNK rolls off the tongue a bit easier, it is best practice to use the full name Tenecteplase, as TNK is a form of TPA, so there's caution to not confuse the two. So a bit more about pathophysiology. So endogenous TPA is a naturally occurring enzyme. and tenecteplase or alteplase binds to a fibrin in a thrombus. It converts the plasminogen to plasmin and then initiates local fibrinolysis with minimal systemic effects. It's cleared rapidly from the liver, and interesting, in alteplase, over 50% is cleared within the first 5 minutes, and then 80% is cleared within 10 minutes. But in tenecteplase, it's a bit longer duration, with 50% cleared in 90 minutes. So now for the main ACT, the alteplase compared to tenecteplase trial, or the ACT trial. This was a large, pragmatic, randomized control trial led out of Calgary, Alberta, by our primary investigator, Dr. Bijoy Menon. So the trial enrolled over 1,600 patients, with almost half of the patients enrolled in Alberta, and they were primarily from Calgary and Edmonton, and also from some of our rural sites, Red Deer and Medicine Hat. The aim of the study was to determine whether tenecteplase given as a single bolus dose might increase reperfusion compared to the standard of care IV alteplase, which is a 10% bolus dose followed by a 90% infusion over 60 minutes. So the ACT trial was a multi-centered parallel group randomized control trial involving patients with acute ischemic stroke who were eligible for IV thrombolysis. The trial was done at 22 primary and comprehensive stroke centers, and primary stroke centers are defined as hospitals with resources and processes to offer IV thrombolysis, whereas comprehensive stroke centers are defined as hospitals to offer endovascular therapy in addition to services provided at a primary stroke center. So eligible patients were randomly assigned 1-to-1, either to IV TNK or to IV TPA. And patients who were randomly assigned to TNK received a one-time bolus of 0.25 milligrams per kilogram to a maximum of 25 milligrams. And those who received the IV TPA received the standard dose, so 0.9 milligrams per kilogram to a maximum of 90 milligrams. And then the TPA was given as a 10% bolus and 90% infusion. The pre and post treatment care was the same for each group, and it was provided according to local standards that are guided by the Canadian Stroke Best Practice recommendations. So some of the baseline characteristics for each group showed very little differences, and these included things such as age. So you can see the distribution of females to males here is quite similar. The baseline NIH was 9 and 10 in each group. Depending on where the occlusion was on CT imaging, it was equivalent based on every type of occlusion available, or showing, I should say. And if there was presence of a large vessel occlusion on CT angiogram, in the TNK group, it was 24.5% and TPA 25%. And then significant metrics with workflow times were also quite similar. So these included stroke symptom onset to hospital arrival, door to CT, and door to needle. And so just a quick note that these workflow times are aligned pretty closely with the Canadian Stroke Best Practice targets. So this really increased the internal validity of the ACT trial. And just for context, the target times from the Canadian Stroke Best Practice are door to CT times within 15 minutes. So you can see for the TNK group, we were right on track. And for TPA, 16 minutes, very close. And then the door to needle time is 30 minutes. So both groups were very close to that target number. The outcomes of the ACT trial were represented in a variety of graphs, and most notable was the forest plot graph, which is the one on the left side of the slide. And so this shows the unadjusted risk differences estimated for the primary outcome, which was the modified Rankin scale. And so for those unfamiliar with the modified Rankin scale, this is a scale that measures the disability or the degree of disability post-stroke. The scale goes from 0 to 6, where 0 indicates no disability post-stroke. 5 would be the highest degree of disability, and a score of 6 represents mortality. So in the forest plot graph, the vertical lines means no effect or neutral findings between the control group and the intervention group. So what the graph tells us is that for most of the subgroups, the majority favor tenecteplase. So you can see that the median number is mostly on this tenecteplase side of the forest plot, but there are a few that kind of don't favor either drug, and those just sit along the neutral line there. The second graph displays the modified Rankin scale scores, and as you can see, the outcomes are slightly favorable to TNK at a score of 0. So with TNK, it's just about 2% higher. And then the rest of the scales are quite similar and equivalent between both groups. This is a table outlining the safety outcomes in patients who received TNK versus TPA, and the trial found no meaningful difference between both groups for safety outcomes. And the most common ones there are the rate of 24-hour symptomatic intracranial hemorrhage, the 90-day mortality from treatment, presence of extracranial bleeding or systemic bleeding, and it was also found that orolingual edema or angioedema was very rare. So some of the results of the ACT trial showed some very significant findings. So the first is that TNK has an equivalent or non-inferior safety profile compared to TPA. Second, it's easy to administer by a single bolus dose, not requiring an infusion. And because of this, it has reduced many dosing errors and significantly improved patient workflow. So for example, our door to needle times, or even the times from, we call it DIDO, so door in, door out times from our primary stroke centers to comprehensive stroke centers. And that's mostly because there's no infusion associated. It's easier to provide the drug and ship the patient right away to a comprehensive stroke center. The third is that it's cost effective. So one vial of Tenecteplase is about $2,200 and one vial of Alteplase is about $2,700, just more. So our savings are approximately $300,000 per year just switching to TNK, based on treating about 548 patients per year. So lastly, the results show that there's improved outcomes with greater recanalization on CT imaging with TNK, and less patients are presented with symptomatic intracranial hemorrhage than patients treated with TPA. Also based on the findings, there were 3 pragmatic benefits of the study. And the first one was a simplified dosing protocol. So I'll highlight this in a subsequent slide later in the presentation. The second is that Tenecteplase is provided as a single bolus dose, which is so much easier for healthcare providers to administer. It requires less equipment such as IV lines and pumps, and it reduces, as I said before, delays from our primary stroke centers to comprehensive stroke centers. The third really interesting benefit is that it improves transport options. So historically, we relied on ACLS EMS crews to transport our patients from primary centers to comprehensive stroke centers. And now BLS crews, if available, may be able to transport patients as there's no more need to monitor the 1-hour infusion. So this might really help with EMS capacity and pressures that they're facing as well. So the ACT trial has led to local and national practice change, which is wonderful. The Canadian stroke best practices were recently revised in the acute stroke management recommendations in late 2022. So in the guidelines under the intravenous thrombolysis administration section, it indicates that Tenecteplase may be considered as an alternative to Alteplase if given within 4.5 hours of symptom onset. And this was all based because of the ACT trial. In addition, Alberta Health Services has recently approved provincial protocols and order sets indicating Tenecteplase is a standard of care for treatment of acute ischemic stroke. Recently we've just finished updating and creating a protocol for Tenecteplase that is a provincial protocol instead of each site having their own. We've also updated the acute ischemic stroke thrombolysis and EVT order set. So there's a paper order set, which is the same as our Epic Connector order set. So all areas across the province are practicing within the same orders, which I think is a wonderful step to take. And lastly, Alberta and AHS is leading the way in stroke care across Canada. So many of our neighboring provinces have been in touch to consult our resources for implementation at their local settings. So after the results were published in July 2022, the practice change to transition to Tenecteplase was endorsed by Alberta Health Services Pharmacy, the Cardiovascular Health and Stroke SEN, the Alberta Stroke Expert Working Group, our EMS colleagues, and executive leaders in AHS. So the transition has been province-wide and it occurred in 2 phases. The first was in all rural areas across Alberta. And while the rural areas transitioned to Tenecteplase, urban stroke centers used up the remaining supply of TPA. And on February 1st, both Calgary and Edmonton will transition exclusively to TNK for treatment of acute ischemic stroke. So very soon, the countdown is on. So fortunately for many nurses and stroke physicians in Alberta, administering Tenecteplase will not be a huge practice change, as many were involved in the ACT trial across many of our sites. So however, here are some of the important nursing monitoring requirements that I thought I would share with the group. So Tenecteplase for stroke treatment is based on weight band dosing. So this is what the weight band dosing chart looks like, and this is has been entered right into ConnectCare within our order sets and in our paper order sets. So important to know is that the dose should never exceed 25 milligrams or 5 mils. And it's important to highlight as the cardiac dosing is double what the ischemic stroke dosing is. So failure to give the ischemic stroke dose could result in intracranial hemorrhage and could be fatal. And it's important to confirm stroke dosing by performing an independent double check with another qualified healthcare professional, as Tenecteplase is a high alert medication, which bears a heightened risk of causing significant harm when used in error. Other notable nursing monitoring requirements are monitoring your patient exactly as you would with an Alteplase treated patient. So there's no change to the pre or post management at all. It's exactly the same as former care with Alteplase. Monitoring for any adverse events such as signs of neurological worsening, clinical deterioration, bleeding, or angioedema are important factors. And lastly, following our provincial protocols and order sets is important for best practice. So I just wanted to share some of the feedback so far that we've gathered from the rural areas as they've transitioned to Tenecteplase. And it's so far been overwhelmingly positive. So number one, there's been no dose errors at all for any patients, which is wonderful. It's overall been very smooth practice change in the rural areas, and I think that's partly because of the familiarity with the ACT trial, and because of other areas providing this drug for patients experiencing MIs as well. Our colleagues in EMS have had a few lunch rounds reviewing case studies of patients with acute ischemic strokes presenting to primary stroke centers, receiving TNK, and then quickly being able to transfer them to a comprehensive stroke center. And they've just said how much quicker this whole process is to literally drip and ship with the patient. One of the important changes of this transition has been the equity of treatment for rural hospitals, as historically the practice has been for rural hospitals to strip directly to a comprehensive stroke center. Because of the ease of administration, they're able to start that process right in the primary stroke centers and bring the patient to a comprehensive stroke center. Another exciting thing is that our data has also improved in the rural areas. So like I mentioned before, we're still waiting on our December data, but our November data so far indicates that our rural areas are faster than before, and even faster than our urban centers. So I'm hoping that this change in Calgary will improve our door to needle times too. The next step is to gather feedback from patients and families about their experience and their lived experience receiving TNK. So I think that's going to be happening over the next few weeks, and it will be published in the AHS YouTube. So stay tuned for feedback there as well. So a few takeaways from today's discussion is that Tenecteplase is a one-time bolus dose administered over 5 seconds, and there's no need for an infusion. Ischemic stroke dosing is not the same as cardiac dosing, and failure to give the ischemic stroke dose could result in intracranial hemorrhage and be fatal. So an independent double check is so important. The pre and post nursing care is the exact same as an Alteplase treated patient. And the Alberta Health Services and Calgary Stroke Program are leading the way for stroke care in the world. And the results of the ACT trial and quick action for practice change in Alberta has inspired other areas around the world to adopt this practice as well. So I just wanted to share a few next steps in Alberta for stroke care. Number one, we have our upcoming stroke accreditation for stroke distinction visit occurring at the end of April. And the ACT trial will be presented as our excellence and innovation project. So it'll be highlighting the excellent research that was performed, and then the national, local, and provincial practice change that resulted because of the ACT trial. And then next up for the stroke world is, I just wanted to share today as a fun fact, is our practice change to increase the window for patients eligible for thrombectomy to 24 hours. So currently at Foothills, we're the only site in Alberta practicing at a 24-hour window. But the hope is to have all sites across the province recognizing stroke symptoms and screening patients who might be eligible for thrombectomy within a 24-hour window. So maybe I can talk about that in a few months, but
Yes, please.
yeah. So that's all I have today. Thank you so much for listening, and I hope it was useful information to share.
Absolutely. Thank you so much, Lindsay. I'm going to stop the recording so we can do questions.